Welcome back to the Motivated Mind Zone. Glad to have you here.
Great to be back.
Today, we are diving deep into something that, well, it comes up constantly, doesn't it? The healthcare systems in the U.S. and Canada.
Absolutely. It's a comparison that's, often filled with anecdotes, maybe some political spin.
Exactly. Lots of heat, maybe not always enough light. So our goal today is to try and provide that light. We're going for a factual, data-driven look.
Right. We're looking at sources that really compare the structures, Canada's single-payer system versus the very mixed public-private setup in the U.S.
We want to look at how they're built, what they cost, who gets covered, who doesn't, and, well, what the outcomes look like.
And it really boils down to understanding the flow of money, the coverage gaps, and ultimately the different choices each country has made. Democratically made choices.
And there's this core paradox right at the start, isn't there?
Yeah.
The U.S. has a massive single-payer system. It's called Medicare, covers everyone 65 and up.
A huge federal program, hugely popular, seen as essential.
Absolutely.
Yeah.
Like touching it is the third rail of politics.
Right.
It's a bedrock for seniors.
Well, then you talk about applying that same idea, public funding for necessary care to people under 65.
And the whole conversation just flips, right? Suddenly it's controversial, debatable, even though the mechanism is right there working for millions of seniors.
Whereas Canada just applied their system, which they also call Medicare, universally. That cultural split doesn't really exist there in the same way.
Okay, let's unpack this. We'll start with the Canadian model. How is it structured? How do they manage costs? Because that leads straight into the whole wait times discussion.
Right, and the controversies around that.
Then we'll pivot to the U.S. We have to grapple with the sheer complexity. Medicare, Medicaid, the employer system, all those layers, and crucially, the gaps.
It's definitely a journey through complexity.
All right, let's start with Canada. Define the system for us, because people hear single payer and immediately jump to socialized medicine.
Yeah, that's a really common misconception. The sources are clear. Canada uses a public spending, private delivery model.
Okay, what does that mean in practice?
It means the government, specifically the provincial governments, mostly acts like the single insurance company. They collect the funds, primarily through taxes, and they pay the bills for medically necessary services.
So, one payer.
One payer, essentially. But, and this is the key part, the people delivering the care, the doctors, the specialists, the hospitals, they are overwhelmingly private entities.
So not government employees.
Generally, no. Your family doctor is likely running their own private practice, working on a fee-for-service basis. They just bill the government plan instead of, Aetna or Blue Cross.
So if I'm in Toronto or Vancouver, my GP is essentially a small business owner.
Pretty much, yes. And the hospitals, while they are typically nonprofit corporations, they aren't state-owned facilities in the way you might think of, say, the VA system in the U.S. They're private nonprofits mostly.
But they get their funding publicly. How does that work, especially for cost control?
That's where the fixed global budgets come in. This is crucial. Provincial authorities give hospitals an annual budget, a fixed lump sum.
And they have to operate within that.
Exactly. They can't just do more surgeries or buy more machines to generate more revenue, like often happens in a fee-for-service hospital environment.
Because the revenue is capped by the budget?
Precisely. It forces administrators to make tough choices, prioritize spending, and be, well, extremely fiscally careful. It's probably the single biggest cost control lever they have.
It sounds like it inherently limits supply, though. If the budget's fixed, you might not buy the newest MRI, or you might limit operating room days for elective stuff.
That's absolutely part of it. That limitation on supply, especially for things not deemed urgent, is a direct consequence, and it's how Canada keeps its overall spending down.
Yeah.
We'll definitely circle back to that when we talk wait times.
Got it. Now, coverage. It's universal, right?
Yes. If you're a Canadian citizen or permanent resident, you're covered by the public plan. And care for medically necessary services is free at the point of use.
Meaning no copays, no deductibles for a doctor visit or hospital stay.
Correct. You show your health card, that's it. This includes things like maternity care, even some infertility treatments if they're deemed necessary.
But the government doesn't pay for everything, does it? I think the sources mentioned a split.
Right. This is another key point often missed in the U.S. The government, the public purse, pays for about 70% of total healthcare spending in Canada.
Okay, so what's the other 30%? Where does that money come from?
That's private spending,
Yeah.
and it mostly covers things that are not included in the universal, publicly funded basket of services.
Like what specifically?
Think prescription drugs taken outside of a hospital,
Right.
routine dental care fillings, checkups and optometry, so glasses, contact lenses, basic eye exams.
Hmm. So those essentials aren't covered universally.
Generally not by the public plan, which is why most Canadians, something like 2/3, have supplemental private insurance.
Ah, usually through their jobs.
Often through their jobs, yes. It helps cover that 30% gap for drugs, dental, vision, maybe private hospital rooms.
Okay, that clarifies the structure. Now, back to cost control. Besides fixed hospital budgets, what else do they do? Drugs are a huge cost everywhere.
They are. And Canada tackles this differently. They negotiate drug prices at a federal level.
Ah, acting as one big buyer.
Exactly. They have a national body that assesses drugs and negotiates prices for the entire country. That collective bargaining power means they often get significantly lower prices than what's paid in the fragmented U.S. market.
That makes sense. Leverage. But if the system is so focused on cost control, how do doctors fare? The sources mentioned a pretty decent average income back in 2012.
Yeah, around 225,000 Canadian dollars pre-tax average. Less for GPs, more for specialists, obviously.
Still quite respectable. How did that work with tight budgets?
Well, part of it is the efficiency of the single-payer administration. Doctors and their staff spend vastly less time and money on billing and administration.
Ah, no chasing down payments from dozens of different insurers arguing about prior authorizations.
Exactly. The administrative overhead is dramatically lower. So while the fees might be lower than in the U.S. for some procedures, the net income is still strong because less of it gets eaten up by, paperwork and billing complexity.
So it shows you can control overall system costs without necessarily impoverishing the providers.
It suggests that, yes, it's about system efficiency.
So wrapping up Canada, for now, the big picture is universality, funded publicly, delivered privately, with strong cost controls through fixed budgets and drug negotiation.
And that low spending is a conscious choice. The sources emphasize this. Canada spends remarkably little on healthcare compared to its peers, especially the U.S. It's a democratic decision to prioritize fiscal conservatism in health, freeing up money for other things.
A trade-off, essentially. Cost control for potential limits on supply or speed.
That's the core tension.
Okay, let's cross the border and dive into the U.S. system. Structurally, the delivery side sounds similar initially, mostly private providers.
That's right. Like Canada, most healthcare delivery is private. About 70% of hospitals are nonprofits, the rest are for-profit. Most doctors work for private groups or hospitals, not the government directly.
But the funding, that's where it gets wild.
Completely different story. It's this incredibly complex mosaic built up over time, piece by piece. You really have to look at the three main ways Americans get coverage or don't.
Okay, pillar number one.
Pillar 1, employer-based insurance. This is the big one. Covers around 60% of the population, mostly working-age adults and their families.
The traditional way many Americans get health insurance.
Exactly. Your job offers a plan. The employer usually pays a chunk of the premium. You pay a chunk. These plans usually cover the basics: doctors, hospitals, drugs, preventive care.
But the quality and cost of those plans.
Hugely variable. That's the critical thing. You could have a fantastic low-deductible Cadillac plan, or you could have a high-deductible plan where you're on the hook for, $10,000 or more out of pocket before the insurance really starts paying significantly.
So just having employer insurance doesn't guarantee you won't face huge bills.
Not at all. Medical debt is a massive issue, even for people with insurance through their jobs. The variability is enormous.
Okay, Pillar 2. This is the big government one. We talked about Medicare.
Pillar 2, Medicare. The federal government's single-payer system for Americans 65 and older, and also for younger people with certain long-term disabilities, covers about 15% of the population.
The U.S. version of universal coverage, but only for seniors.
Right. And what's fascinating here is how incredibly complicated even this single-payer program is. It's not just one thing. It's broken down into parts. A, B, C, and D.
Okay, let's take a minute and break those down. People hear Medicare but might not know the layers. Part A.
Part A is basically hospital insurance. It covers inpatient hospital stays, care in a skilled nursing facility after a hospital stay, hospice care, some home health care.
And how do you pay for that?
If you or your spouse paid Medicare taxes while working for about 10 years, you generally don't pay a monthly premium for Part A. It's prepaid through taxes.
Sounds good. Free hospital care.
Well, not quite free. There's still a deductible for each hospital benefit period. In 2024, it was over $1,600 just for one stay, and there are co-payments for long stays.
Okay. $1,600 right off the bat is significant for someone on a fixed income. What about Part B?
Part B covers outpatient services. Think doctor visits, lab tests, diagnostic screenings, medical equipment, ambulance services, preventive care.
The stuff you need outside the hospital. How's that funded?
This one has a monthly premium. Most people pay it. It often comes right out of their Social Security check. It's subsidized by the government, but it's not free.
Yeah.
And after you meet a small annual deductible,
Yes.
Part B generally only covers 80% of the Medicare-approved amount for most services.
Wait, 80%. So seniors are responsible for the other 20% of potentially huge bills for specialists or cancer treatments.
Exactly. That 20% coinsurance has no annual limit in traditional Medicare. It could be financially devastating for someone with serious health needs.
So how do people manage that? That sounds like a massive gap in the single-payer system.
It is. And that's where the private insurance market immediately jumps back in, even within Medicare. Most seniors, something like 90%, have some form of supplemental coverage. Often, it's a private policy called Medigap.
Medigap.
Yeah, these are plans sold by private insurance companies, specifically designed to fill those gaps in original Medicare, primarily the Part A deductibles and that 20% Part B coinsurance.
So you need to buy another private plan on top of the government plan to make it affordable.
For most people using traditional Medicare, yes. Medigap is almost essential to cover those unpredictable out-of-pocket costs.
Wow. Okay. The complexity. And we still have Part C and D.
We do.
No.
Part C is Medicare Advantage. This is an alternative to getting traditional Medicare Parts A and B. Instead, you can choose to enroll in a private health plan, like an HMO or PPO that contracts with Medicare.
So private companies offering Medicare.
Basically, yes. The government pays these private plans a set amount per enrollee, and the plans have to provide at least the same benefits as original Medicare Parts A and B. They often bundle in extra benefits, like some dental or vision, to attract members.
What's the catch?
Usually the trade-off is network restrictions. Medicare Advantage plans typically have limited networks of doctors and hospitals you can use, whereas traditional Medicare lets you see almost any doctor who accepts Medicare anywhere in the country.
More complexity, more choices, more potential pitfalls. And finally, Part D.
Part D is the prescription drug benefit, and this part is almost entirely run by private insurance companies.
Not the government directly.
No. Private companies design and offer dozens of different Part D plans in each region. They're approved and subsidized by the federal government, but seniors have to actively choose and enroll in one of these private plans to get coverage for their medications.
So navigating the drug coverage market is another task for seniors.
A very complex one. Choosing the right Part D plan can be confusing, and plans change every year.
Unbelievable. Okay, that's Medicare. Pillar 3 is Medicaid, right? The safety net for the poor.
Pillar 3, Medicaid. This is fundamentally different. It's a joint federal and state program. The federal government sets minimum standards and provides matching funds, but the states actually administer the program.
So it varies a lot state by state.
Immensely. States decide who is eligible beyond the federal minimums, what benefits are covered, and how much they pay doctors and hospitals. Some states are quite generous, others are much less so.
And the sources really hit hard on the eligibility rules, particularly around poverty levels.
Yes, the federal poverty level itself is very low. And traditionally, Medicaid eligibility wasn't just about being poor, it was about being in certain categories.
Right.
Like being a child or pregnant or disabled or very low-income elderly, often in nursing homes.
But what about just a regular adult, maybe working minimum wage, who doesn't have kids?
And here's the aha moment, the really crucial gap the sources highlight. In most states that didn't expand Medicaid, childless adults generally do not qualify for Medicaid no matter how poor they are, even if they have zero income.
Zero income, no kids, no coverage from Medicaid.
In many states, that's the reality. You fall straight through the cracks.
That seems shocking. Was that supposed to be fixed?
It was. The Affordable Care Act, the ACA or Obamacare, aimed to fix exactly that. It intended to expand Medicaid eligibility to nearly all adults with incomes up to 138% of the federal poverty level.
Covering those childless adults.
Yes, closing that huge gap.
Well,
But-
Supreme Court ruling.
Right. The Supreme Court made the Medicaid expansion optional for states. And about a dozen states, as of today, still haven't expanded.
Leaving millions of people in that gap.
Estimates are around 2 million people now, still stuck. They make too little to get subsidies for private insurance on the ACA marketplaces, but they don't qualify for their state's restrictive Medicaid program because they don't have kids or a qualifying disability. They're uninsured simply because of the state they live in.
Plus, there are other government systems like the VA for veterans, TRICARE for the military. It's a patchwork.
A real patchwork.
Which brings us to the money paradox. The U.S. government runs Medicare and funds a huge chunk of Medicaid.
Right, plus the VA, plus subsidies for ACA plans.
So the government covers maybe a third of the people?
Roughly, yes, through all its various programs. But if we connect this to the bigger picture, that public spending accounts for about 2/3 of the total national health care bill.
Wait, say that again? The government covers a third of the people but pays 2/3 of the cost.
That's the staggering figure from the sources. Billions and billions through Medicare and Medicaid, over $536 billion for Medicare, $414 billion for Medicaid in the years studied. Because healthcare is so expensive in the U.S., and because the government covers the sickest, elderly, disabled, very poor, the public sector ends up footing the majority of the nation's total health expenditure.
So the government is already the dominant payer in the U.S. system by dollars spent.
By a significant margin.
Yet the system remains fragmented, incredibly expensive, and leaves millions completely uninsured or underinsured.
That's the core paradox of U.S. healthcare financing. Massive public investment, yet incomplete and inefficient results compared to other systems.
Okay, we've seen the complexity of the U.S. and the controlled approach of Canada. Now, whenever these two systems are compared, especially in the U.S., certain criticisms or myths about the Canadian system always pop up. Let's tackle those. Myth number 1.
Myth 1. Doctors are fleeing Canada for the U.S. You hear this constantly, right? Oh, I know a Canadian doctor who came here because they couldn't stand the system up there.
Yeah, it's almost a cliche. Lower pay, bureaucracy, they all want out. But the data...
The data tells a completely different story. First off, Physician satisfaction surveys consistently show Canadian doctors are actually more satisfied with practicing medicine in Canada than U.S. doctors are with practicing in the U.S.
Really? Why would that be?
Less administrative hassle is a big one. Not dealing with multiple insurers, lower malpractice insurance costs, maybe a different work-life balance focus. While top-end specialist pay might be lower, the day-to-day practice environment is often rated higher.
Okay, satisfaction is one thing. What about actual movement? Are they leaving?
The Canadian Institute for Health Information tracks this closely. There was a period, maybe in the 90s, where emigration ticked up maybe 400 or 500 doctors leaving annually, which sounds like a lot, but it's a tiny fraction of all doctors in Canada.
But what's happened since then?
Here's where it gets really interesting. Since around 2003, that trend completely reversed. Net emigration turned into net immigration. More foreign-trained doctors, including some from the U.S., are moving into Canada to practice than Canadian doctors are leaving.
So the brain drain narrative is just wrong. Outdated, at least.
Empirically, yes. The flow is now net inward. The myth persists, but the numbers don't back it up.
Yeah, myth busted. Myth number 2, maybe the biggest one. Canadians are flooding south to the U.S. to get medical care because of wait times.
Ah, yes, the medical tourism argument. Canadians desperate for a hip replacement or an MRI supposedly driving across the border in droves.
It fuels the whole socialized medicine fails narrative. What did the research find?
There's a fantastic, really comprehensive study on this, published in the journal Health Affairs. They called it Phantoms in the Snow.
Appropriate title.
Because they found this supposed flood of patients is largely a phantom. They used 3 different methods to try and find these cross-border patients.
Okay, method 1.
They surveyed healthcare facilities right along the U.S. border in Michigan, New York, Washington State. Places Canadians would likely go first?
And did they find them?
Hardly. About 80% of the facilities saw fewer than 1 Canadian patient per month, and 40%, nearly half, had seen 0 Canadians seeking care in the entire previous year.
Wow. 0. But some must have come across.
A tiny number, yes. But when they looked at why those few Canadians sought care in the U.S., over 80% of the visits were for emergencies or urgent care.
Like a tourist breaking an arm.
Exactly. Or someone needing unexpected care while visiting. Only about 19% of those already rare visits were for elective reasons, the kind of thing you'd supposedly cross the border for to beat a wait list.
So not exactly a flood of people scheduling surgeries. What was method 2?
They surveyed the best hospitals in America, the top-tier places like Mayo Clinic, Cleveland Clinic, etc. The thinking was, if Canadians are coming for high-end elective care, they'd go to the best.
Makes sense. What did they find there?
Even at these elite centers, the numbers were minuscule. Only 1 hospital reported seeing more than 60 Canadians in an entire year. And that included emergencies and elective care. Again, statistically insignificant for a country of nearly 40 million.
Okay, so border clinics aren't seeing them. Elite hospitals aren't seeing them. Method 3.
They went directly to the source, Canadians themselves. They used data from Canada's large National Population Health Survey. Out of 18,000 Canadians surveyed,
How many reported getting care in the U.S. in the past year?
only 90. 90 people out of 18,000.
Okay, that's tiny. And were those 90 getting elective care?
Get this, only 20 of those 90 said they went to the U.S. electively for care. 20 people in a huge national survey.
So the evidence seems overwhelming. The flood is a trickle, at best, and mostly for emergencies or maybe very wealthy people seeking niche procedures.
Precisely. It's an anecdote, a meme almost, that doesn't reflect reality for the vast majority of Canadians or the system itself. Phantom busted.
All right, that leaves myth 3, which feels like it has more basis in reality. Canadian wait times are terrible because the system rations care, maybe denies it to people, especially the elderly, needing things like hip replacements.
Yeah, this one definitely holds the most water in terms of having a factual basis. There are wait times. But the reason for them, And the idea of rationing or denial needs clarification.
So, stories of grandma being told she's too old for a hip replacement.
Those are largely false, according to the sources.
Yep.
If a procedure like a hip replacement is medically necessary, the public system covers it.
Yeah.
There is an age-based denial like that. And think about it. Who pays for most hip replacements for the elderly in the United States?
Medicare, the U.S. single-payer system for seniors.
Exactly. Single-payer systems do cover these common, necessary procedures for the elderly. Canada's is no different in that regard.
Okay, so if they're not denying necessary care, why are there sometimes long waits, especially for specialists or certain elective surgeries or diagnostic scans like MRIs?
It comes back to what we discussed earlier. It's a direct result of the conscious, democratic choice Canada made to control costs by limiting supply.
The fixed hospital budgets, the limits on expensive equipment.
Yes. They deliberately chose to be fiscally conservative with healthcare spending. The wait times, particularly for non-urgent elective things, are the trade-off they accepted for universal coverage at a much lower national cost.
So it's not rationing in the sense of arbitrary denial, but rationing by waiting list, driven by budget constraints.
That's a better way to put it. They limit the capacity, fewer MRI machines per capita, maybe fewer orthopedic surgeons doing elective joints per capita than in the US, and that creates a queue for non-urgent things. It's a way to manage demand without spending vastly more money.
They prioritize urgent care, cancer care, things that are life-threatening.
Absolutely. Wait times for those critical services are generally comparable to other developed nations, including the US.
Well,
The longer waits are concentrated in elective areas.
did Canada fix the wait times if they wanted to?
The sources suggest yes, almost certainly. If they chose to spend significantly more money closer to US levels, perhaps they could increase capacity, buy more machines, train more specialists, reduce the waits.
But they choose not to.
As a country, they've historically chosen not to prioritize that extra spending on speeding up elective care, preferring lower taxes, or funding other social programs. It's an ongoing political debate within Canada, of course, but the structure itself is based on that foundational choice of fiscal prudence.
Wait, I have to push back a little here. If you're the person waiting 6, 8, 10 months in pain for that hip replacement, does hearing it's a conscious democratic choice for fiscal conservatism actually help? Isn't that still a form of rationing that really impacts quality of life?
That's a very fair and important point.
Yeah.
From the system level, the policy level, it is a conscious trade-off made by the government representing the collective will, balancing costs against access speed. But for the individual patient experiencing that delay and that pain, yes, absolutely, it feels like rationing. It is a delay for a needed service. The system prioritizes collective fiscal health and universal access over individual speed for non-urgent procedures. That's the fundamental difference in philosophy compared to the U.S. market-driven approach, which often offers speed, but at a tremendous cost and with significant gaps in access.
A really difficult balance. Okay, that helps clarify the wait time issue. It's real,
Yeah.
but it's a consequence of deliberate cost control, not arbitrary denial. All right, we've dug into the mechanics of both systems, busted some myths. Let's try to synthesize this. What are the core philosophies driving these two different approaches?
Canada's choice fundamentally is universal coverage achieved through single-payer public funding, delivered mostly privately, with costs aggressively controlled via government negotiation and limiting supply capacity.
The result being lower overall cost, but yes, those wait times for elective things is the main trade-off.
Exactly. The U.S. choice. It's private market dominance in both insurance and delivery, layered with complex, expensive, and segmented public safety nets, Medicare and Medicaid.
Which leads to, what? Massive spending, incredible complexity.
The highest healthcare spending per capita in the world by far. Yet, despite that spending, significant gaps remain: millions uninsured, millions more underinsured, facing potentially crippling out-of-pocket costs.
So vastly different approaches, vastly different spending levels. What about the results, the health outcomes? Does the U.S. get significantly better health for all that extra money?
This is perhaps the most striking point in the comparison. Despite the U.S. spending over 50% more per person than Canada, the overall population health outcomes are otherwise comparable.
Comparable, not dramatically better in the U.S.
Generally not, no. On many key metrics, life expectancy, infant mortality, rates of preventable deaths, Canada performs as well as or sometimes slightly better than the U.S., all while spending vastly less.
So what does this all mean when you boil it down?
It means the U.S. system stands out as a global anomaly. Its complexity and cost are unparalleled, and that high spending doesn't clearly translate into superior overall health for its population compared to a system like Canada's.
And Canada demonstrates.
Canada demonstrates that achieving universal coverage through a single-payer funding model while controlling costs is entirely feasible for a developed nation. It does involve trade-offs, particularly around wait times for non-urgent care, which stem directly from those cost control choices. But it shows it's possible.
The key seems to be that funding mechanism. Public funding, private delivery, works in Canada because the single payer controls the flow of money and sets the rules.
Precisely. Whereas in the U.S., the fragmented funding employers, Medicare Parts A, B, C, D, Medigap, state Medicaids, the uninsured creates the complexity, the administrative waste, the gaps, and fuels the high costs. The funding structure is the problem in many ways. Hashtag outro.
Well, that brings us to the end of this deep dive. We've covered a lot of ground.
We certainly have.
We looked at Canada's model, single-payer funding, but private delivery, using tools like global hospital budgets and national drug negotiation to keep costs down.
Right, resulting in universal coverage, but those wait time trade-offs.
And contrasted that with the U.S., the patchwork of employer insurance, the intricate layers of Medicare Parts A through D plus Medigap, and the state-by-state variability of Medicaid, which still leaves that critical gap for low-income childless adults in some states.
A system marked by incredible spending and complexity.
Hopefully, understanding these mechanics helps you, our listeners, see past the headlines and the political rhetoric.
Yeah, to grasp the actual choices and consequences embedded in how these two nations decided to organize and pay for healthcare, it's less about ideology sometimes and more about these nuts and bolts decisions.
Which leads us to our final provocative thought for you to take away and consider.
Right. We talked about Canada making a conscious choice for fiscal conservatism, accepting wait times to keep spending low and universal. Now consider the U.S. We established the U.S. government already pays for about 2/3 of the entire national health care bill through Medicare, Medicaid, VO, subsidies, etc. Yet it only directly covers about 1/3 of the population. So this raises an important question. If the U.S. government is already the dominant payer, footing 2/3 of the massive bill, why has that immense public spending resulted in such a complex, inefficient system with such significant gaps in coverage, especially when compared to universal systems that achieve comparable outcomes while spending far, far less?
Why doesn't that huge government spending translate into a simpler, more complete safety net?
Exactly. It's a fundamental question about value, efficiency, and national priorities for those public dollars. Something to mull over.
A really powerful question to end on. Thank you for joining us on the Motivated Mind Zone for this deep dive. We'll catch you next time.
Thanks, everyone.